The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. On behalf of the Academy of Doctors of Audiology, I would like to welcome you to today's Audiology Project webinar, The Diabetic Imbalance, Dizziness, Vertigo, and Falls. My name is Brian Doty, and I'm pleased to serve as today's course moderator. At this time, I'd like to introduce Dr. Kathy Dowd, CEO of the Audiology Project. Kathy?
Thank you so much, Brian. I just want to give a special thanks to the Academy of Doctors of Audiology for hosting our webinars. This is the fourth in a series of webinars this year on diabetes-related hearing and balance issues. As you know, the Audiology Project is a nonprofit. You can find us on the web at theaudiologyproject.com. If you're interested in research articles, or if you want to volunteer for state cohorts, or if you have any questions. But thank you so much for attending. Back to you, Brian.
Thank you, Kathy. Just a few housekeeping items before we begin. Please type your questions into the question queue and we will address them at the end of the presentation. Following today's session, you will receive an email containing all the information needed to apply for continuing education credit through the American Academy of Audiology. All attendees will receive a general attendance certificate within 30 days of the course. The slides from today's presentation will be distributed in the post-webinar email. Today's presentation is also being recorded and will be available for download next week. At this time, it's my pleasure to introduce today's course leader, Dr. Richard Gans. Auditory vestibular physiology and neuropsychology. Dr. Gans is a research science member of the American Academy of Neurology and the American Academy of Otolaryngology. He has presented over 200 programs worldwide and is the author of numerous textbooks, chapters, textbooks, and journal research articles. Dr. Gans is past president of the American Academy of Audiology and is a recipient of the Academy's Distinguished Achievement Award in 2016, as well as receiving an honorary doctorate of humane letters from A.T. Still Health Sciences University. His current areas of interest and research include pediatric balance, migraine, BPPV, psychogenic balance disorders, rehabilitation of the diabetic and Parkinson's patient, and concussion management. Please welcome Dr. Richard Gans.
Thank you, Brian. And I'd like to thank Kathy Dowd and, of course, the Academy of Doctors of Audiology for their support in this important undertaking. We're ready. Just to let the audience know, I'm not in control of the slides, so I am going to need to ask Brian to advance slides as we go along. So Brian, I think we're ready to go with the first slide. Well, first of all, let's talk about issues of dizziness and vertigo and falls, even before we drill down into the realm of a comorbidity of diabetes. This is not a new issue. The boomers, born between 1946 and 1964, the world has known that they are coming. And as early as 1994, the National Institutes of Health Strategic Research Plan identified specifically dizziness, vertigo, and falls as a potential catastrophic healthcare issue. Now, it depends on whose data you look at. So we look at comorbidities, not of just diabetes across the entire lifespan, but when one looks at the comorbidity of diabetes, particularly in the adult or aging population, it's quite large. Now, again, we're going to see a variety of different numbers depending if we look at CDC or NIH, but it's estimated that over 9,000 folks in the U.S., or approximately 29 million people, according to 2014 data from CDC, are identified as having diabetes. Now, we're going to break this down a little bit because we want to talk about not only a diabetic patient, but a pre-diabetic, and we'll talk about why in a moment. Can we move on, Brian? Before we do, let's just all agree on what we're going to do today. So our course is going to provide attendees with an overview of the effect of diabetes on the three primary sensory modalities of balance. Because remember, balance requires visual, vestibular, and somatosensory modalities. We're going to spend a lot of time actually looking at a review of the literature, which is quite extensive. What I've also tried to do is make sure that the literature is up to date. I believe that probably half of all the references we'll be using actually have been published in the last 18 months. So we're also going to then look at this from the standpoint of an audiologist, being that this is being supported by the Academy of Doctors of Audiology. What can the audiologist do? What is the role of the audiologist in working with this very, very common comorbidity seen in audiology, ear, nose, and throat type of clinics? And what can we do to mitigate the potentially life-altering implications of the comorbidities of dizziness, vertigo, falls, and diabetes? Brian? So our objectives are going to be, we're going to hope that at the end of our time together today, you're going to be able to list the changes that occur in each of the sensory modalities. You're going to be able to name those vestibular balance tests which have the greatest sensitivity to diabetic-related changes. And then 3, describe best practices to implement identification and intervention protocols within a diabetic fall risk management program. Brian? Okay, so good question. You're an audiologist. Now, depending whose data we're using, how many audiologists are actually out there practicing? Is it 12,000? Is it 14,000? Is it members of AAA? Is it individuals who are members of ADA? Is it members of the ASHA? I mean, how many people are really out there? And of this, somewhere between 12 to 14,000 individuals, what percentage of audiologists are involved with actual balance or vestibular? Well, the fact is it's relatively small. So then the question might be, well, why are we even talking about this? Because audiologists, for the most part, are seeing diabetic patients. Whether you are including this in your interview, whether you are thinking about it as you interact with patients with hearing and balance disorders, the reality of it is that more than 28% of people with diabetes, age 40 or older, have diabetic retinopathy, which simply means they have reduced vision. Now, as an audiologist, if you're fitting hearing aids, I don't know if you've noticed this, but they're pretty small. Those hearing aid batteries are pretty small. And if almost 30% of people age 40 and older who are diabetic have retinopathy, can they see the controls of the hearing aid? Can they see the batteries? Can they see the demonstration that you're doing with them on the product? We also know that hearing loss is about twice as common in adults with diabetes as those who don't have diabetes. Now, it's not really surprising, is it? The inner ear, so when we talk about the inner ear, we want to talk about hearing imbalance, has the smallest blood supply of any organ in the human body. And what do we know about diabetes? It's really a disease or disorder of the capillary system. And that's why we see so many components of the sensory modalities adversely affected. We know that a very high percentage, somewhere greater than 50% and almost 3/4 of individuals with diabetes have a mild to severe form of neuropathy. Now, when we talk about neuropathy as it relates to balance, we very often are going to talk about neuropathy of the lower extremities, right? Feet and legs below the knees. Now, obviously that affects balance. But again, for those of you who are dispensing hearing aids, I'll just throw this out to you, that you have an individual with a hearing loss that you're thinking about fitting with an appliance that has reduced vision and neuropathy, which can be in the digits as well. So their fingers and hands may not have the feeling or sensitivity to change those batteries or maintain their hearing aids as they should. But as it relates to balance, what we know is that the research suggests that up to 46 or close to 50% of individuals, twice the normal population of diabetics, have will get BPPV within their lifetime. So it's important to understand that diabetes is going to affect all aspects of the hearing and balance system. And so this is some information from the American Diabetes Association that just gives you some of these staggering numbers as to the prevalence and the other situations. It's also important to think about, particularly in underserved populations, which may be Hispanic or the non-Caucasian families that you will see, that there is a racial disparity. So it's important to understand that there are many different aspects when you're dealing with your patient that can affect whether or not they have diabetes and how you need to manage them perhaps differently or with a new level of sensitivity as to what is going to be in their best interest. Brian, next, please. Now, very often we don't talk about pre-diabetics. We just talk about the number of individuals with diabetes. But if you look at this number, this really is going to get your attention. Now, why is this so critical? Because the changes don't necessarily occur like a light switch. They occur more like a dimmer switch. Now, look at this number. Now, we talked about maybe 29 million Americans with a medical diagnosis of diabetes. But it's estimated, according to the National Institutes of Health, that over 84 million, or 1 out of 3 Americans, has a condition of prediabetes. And what's even more important is that 9 out of 10 of these individuals don't even know they have it. Now, why is this so important? Because the retinopathy that we talked about, the vestibulopathy that we talked about, the neuropathy that we talked about, all the different things that are going to adversely affect balance or cause dizziness and vertigo, including benign paroxysmal positional vertigo, which is twice as prevalent in the diabetic population. We also need to realize that the pre-diabetic population is also going through those changes. It doesn't happen magically that when someone receives a formal medical diagnosis from their physician, nurse practitioner, whoever that health professional is, that they are now officially diabetic. So this is something to talk to your patients about. What is their overall health? What's going on with their blood sugar levels, weight, cholesterol levels. If you have individuals that are non-Caucasian, as you can see from the data, this population may already be underserved and is not receiving some of the information that would be helpful to them as far as maintaining a good, healthy lifestyle. Brian? So how do we bring all of this together? Right? So dizziness, vertigo, and falls will affect over 35% of the U.S. population, people over 40 years of age. This is the Agrawal study, which we're going to be talking about, certainly brought this to the fore. Now, the scientific literature indicates that a higher prevalence, maybe as great as 70% are within the population with diabetes. And this demographic includes many older adults over the age of 70, which have a greater incidence of comorbidities, which places them at a further elevated fall risk. Because we have to always be cognizant of the fact that as people move into the 6th, 7th decade of life and beyond, that they may not be troubled merely by the effects of diabetes. In addition to that, they may have glaucoma, they may have hypertension, they may have the influence of polypharmacy, of cardiovascular, pacemaker. So diabetes in and of itself may not be in isolation. Okay, Brian. So let's look at the scope of problem. Let's look at the relationship and implications of diabetes to dizziness, vertigo, and falls. And then let's talk about what we might be able to do to help our patients to reduce their risk of falls in particular. Brian? Regardless of any medical comorbidities, dizziness is considered the #1 complaint of all persons, with or without diabetes, over 70 years of age. According to Hopkins, 85% of vertigo and balance dysfunction may be inner ear related. 50% of all individuals over age 70 will experience benign paroxysmal positional vertigo at least once. And as we say, it's only benign if you're not the one who has it. We have to remember that older adults with BPPV have a greater incidence of depression, falls, and reduced activities of daily living. Right? Let's look at the impact of falls on the general population. Now, keeping that in mind, what is one of the things that we're always concerned about with individuals with diabetes? That's wound care. So that when a person with diabetes falls and is injured, okay, their recovery may be prolonged or may not nearly be successful or may have a number of other implications because of their inability to heal as non-diabetic individuals might. So falls are the leading cause of traumatic brain injury and bone fractures. The 3 most common fractures are the femur, the wrist, and the hip. Now, one of the reasons that the wrist is so common is because of what we call the parachute response. So when you start to lose your balance, you throw your arms out and you put your hands up. Now, the parachute reflex begins to dissipate in our 70s and beyond. This means that the older adult who falls may not be breaking their fall with their wrist, their hand, but they may be breaking the fall with their skull. And this is why the traumatic brain injury is such a big problem for the older adult who falls. Falls are the leading cause of accidental death in all persons over 65 years of age. And it ranks as the 6th leading cause of death for the elderly. Now, what we know is the older an individual is, the more likely there is going to be mortality, not just morbidity, associated with this. And probably this is because, as you'll see, that those who sustain a hip fracture, 20% of them will not be able to survive that year. And that's because they're frail. It's not from the fracture itself, right? And those who do fall, 20% will require placement with a long-term care facility. Now, this goes back to quality of life. What we know for a number of years now is that the mantra in the world of gerontology is successful aging means aging in place. People want to stay in their homes. They want to care for themselves. They don't necessarily want to live with a relative or an adult child. They may not have the ability to live in some sort of a retirement, ALF, or nursing type facility for a wide variety of reasons and don't wish to. But if you have a sustained traumatic brain injury and you can't remember whether you leave the stove on, if you can't remember if you took your medicine, if you can't remember if you ate lunch, then you begin to have a downward spiral. And it's estimated that 40% of individuals who have to be institutionalized in some sort of a age-appropriate facility do so because it is no longer safe for them to ambulate within their own home. Brian? Now, I'm trying to provide you with really up-to-date information. This just came out literally days ago. This appeared in the Bloomberg talking about, goes back to what I was talking about with the boomers. If you look at these numbers, they are staggering. The numbers begin to go way beyond what we thought was going to happen. But what you're seeing here is that, everyone kind of thought maybe 25, 30 years ago that the boomers were going to be healthier than their parents. And if you recall, the boomers' parents are the greatest generation, right? The individuals who lived through the Depression and lived through World War II. Well, the reality of it is that the boomers aren't necessarily any more healthy than their parents were. So if you look at this, you're talking about an increase in falls from a few years ago, 2007, to the data from 2016. I mean, these numbers are actually staggering. So if you look at the number of deaths, they're significantly higher. They jump from a little over 18,000 to almost 30,000, right? And then when you break it down into the older population, particularly those 85 and older, who we consider to be the old, we're looking at an increased population of about 9 million people within a few very short years. And then when you add those chronic conditions, as we were talking about, the other non-diabetes related comorbidities, arthritis, polypharmacy, and the effect on gait and balance, you're talking about 95% of hip fractures caused from a fall. And if you want to think about national debt or student debt or real estate debt or any kind of debt you want to think about, look at the staggering number in 2015 of medical costs for falls beyond $50 billion. Mind-boggling. So we all have skin in the game. It's not just about managing the pain and suffering of the older adult who falls, but we're all contributing to this amazing amount of money that's being spent when we fail to identify and intervene in any high-risk population. And certainly the diabetic population is perhaps at greater risk than any other population group of seniors. Brian? What we know about balance is that balance is considered the sixth sense, right? And there's not just one component that manages balance. Balance is a very elegant interaction between the balance systems of both ears, our eyes, visual, somatosensory, our sense of touch, and our central nervous system. This engages the brainstem, the cerebellum, the cortex, and our descending motor responses. I'm sure some of you have parents or grandparents that almost embarrassingly will say to you, "Oh, it was my fault. I wasn't looking. Oh, it was my fault. I saw the curb, but I didn't pick up my foot." Right? You've all heard this. I know you have, because this is what we listen to here at the Institute every day. Well, the reality of it is when one or more of these sensory modalities is impaired, or the central nervous system and the motor output is not operating properly, you can't be careful enough. The reality of it is gravity always wins, gravity always works. Brian? So the risk of falling is increased with diabetes. Okay, we know this. We're going to share a lot of literature with you. Diabetics are 70% more likely to have vestibular dysfunction than individuals without diabetes. Right? Now, when you look at conditions like retinopathy and neuropathy, if we take those away, right, diabetics are still more likely to have vestibular dysfunction. And although retinopathy and neuropathy contribute to a cascade effect, it's estimated that the vestibular dysfunction alone, even in the absence of visual or somatosensory dysfunction, is a greater cause of falls. Right? So, what else do we know about patients with diabetes? Increased prevalence of benign paroxysmal positional vertigo, which we know from the literature increases fall risk at least by 2. Reduced sensory input from the inner ear, the balance system, vision, lower extremities, cumulatively create a complex interaction of dysfunction. In other words, the individual with diabetes is presenting the perfect storm. And again, those individuals, 40 years of age and older, have a much higher incidence of falls. Brian? Let's take a look at this overview, which was published by De Silva and their group. And this is wonderful, particularly for audiologists who are familiar with some of the vestibular tests that they're talking about. So there are a wide variety of studies that show the type of abnormal findings that one might expect. In Baruin's study, they found that almost 22% of the participants with DM, diabetes mellitus, had bilaterally depressed caloric responses. Now, audiologists, that's a big deal because what you're going to find is that this is not like patients that have an acquired unilateral. You know, if you have an acquired unilateral vestibular loss, secondary to vestibular neuritis or something like that, then essentially the brain has the ability through central compensation to learn how to fly the plane, if you will, with one bad engine. That's basically what happens. Central compensation occurs in the brain, in the brainstem, in the flocculus, and in the cortex. The ear never recovers. The brain learns how to fly the aircraft on one engine. When you have bilaterally depressed calorics, what that basically means is you cannot adapt, okay? The brain goes into substitution mode, which means that you have a defective set of gyroscopes, the vestibular system, and this individual has got to use eyes and touch to substitute for the vestibular system. Well, what do we know? The diabetic individual has retinopathy and neuropathy. So those two backup systems may not be that great. Now, what we also see from Gowron in their study is impaired optokinetic responses and also increases in spontaneous and positional nystagmus. This is not unusual. You're going to see some research that Richard Roberts, Sam Biddle, and I just published the end of last year that shows that individuals with a comorbidity of diabetes are more likely to have some patterns of spontaneous nystagmus. Now, this is more likely due to microvascular diseases within the brainstem. Nicholson and their group found some difficulty in gaze stabilization. And Cohen and his group found a prevalence of patients with BPPV. So we can begin to see that there's a wide range of abnormal findings. It's not just one abnormality or one particular test. We're going to look at that also. I provided you with a real good new article coming out of Iran, actually, on the effect of diabetes mellitus on the vestibular evoked myogenic potential. Brian? Again, we've got more studies here. Klagenberg, again, found a very high incidence of canal paresis or caloric abnormalities, whatever you would like to call it, spontaneous nystagmus, positional nystagmus. Again, it's important to know that when we're talking about these forms of nystagmus, that we're not talking about BPPV. Agarwal found that using a modified CAT-SID, there was a very, very high incidence of postural instability when vision was denied or when individuals were on a dynamic surface. Now, what that means is you say, well, people aren't walking around with their eyes closed. Yes, that may be true, but if the lighting is not optimal, if there is increased glare, if there are visual distractions, we can have all different kind of problems. Kim, in their study, again, found all different types of abnormalities on gaze testing, positional testing, VNG, caloric test. 60% closely had vestibular dysfunction using the abnormal caloric responses. Chavez and Delgado found a much higher rate of complaints of dizziness, as well again as this common denominator of the abnormal caloric responses. Di Stefano and Dispenza are good friends from Palermo, Italy, who we've collaborated with over the years, found that the recurrence of BPPV was related to a number of comorbidities, particularly when you look at a combination of hypertension, diabetes, osteoarthritis, osteoporosis, increased the risk of recurrence to almost 6.5 times. So that is really something that you need to look at. You know, when your BPPV is so common, and so we, you know, here at AIB, we've treated over 14,000 patients with BPPV since 1994, and we know what our recurrence rates are. And for the general population, the recurrence rate should only be probably 5 to 10%. Well, with the diabetic patient, it's 6 times that. So we need to always be aware when we're treating the diabetic population that they, in fact, are going to be different than our patients without diabetes as it relates to recurrence rates. Brian? Okay, so what do we know? We know that diabetes is a problem. We know that diabetes is a problem as it relates to dizziness, vertigo, and falls. Now, I'm not going to go into each of these, but De Silva does a wonderful job. And again, this is a pretty recent publication, 2016. They do a wonderful job of beginning to show evidence-based, because again, everything we want to do is evidence-based, right? If you didn't measure it, it didn't happen. Is there something we can do? Now, as I said, gravity always works, gravity always wins. But does that mean that falls are inevitable for the older population with diabetes, or is there something that we can do? And what we are able to see is in that relatively short term, if you look at, for example, if you look at the 1, 2, 3, 4, 5th, if you look at that 5th column and you look at duration, the studies that De Silva's group are reporting ranges from as short as 3 weeks to as long as 12 weeks, but many of them are quite short. And what do we see? If we look at the results, without going into every single one of these, but this is very important. What this means is, for our colleagues in physiotherapy, rehabilitation medicine, just as we're seeing in many other chronic conditions, okay, there are many chronic conditions at one time that physical therapy was believed to be contraindicated. Parkinson's disease, we now know what? Parkinson's disease responds extremely well to a combination of physical therapy and cognitive behavioral therapy. Even multiple sclerosis, which was viewed to be a movement disorder that was absolutely contraindicated. The data is now beginning to emerge that physical therapy is a significant benefit for many individuals. And we're now seeing this for the diabetic patient as well. Now, what's interesting is this due also to just a more an escape from a more sedentary lifestyle? What we know is that exercise, of course, is going to help with all aspects of strengthening. Remember, your bones don't stay up by themselves. Your bones stay up because of your muscle mass. So being active, getting off the couch, whether it's walking, light weight training, any of these activities that are supervised and medically recommended, where there's no contraindications, are of great importance. So the data certainly suggests that we simply need to get off the couch, out of the house, and start doing something to reduce the risk of falls and to improve postural stability under challenging conditions. So this is very, very encouraging. Brian? Now, I've got all of the references for you on the last two slides. So we don't have, if this was a 12-week semester, what we would do, of course, is report on all of these, but these are kind of impact. I was talking to Dr. Dowd before our conversation began. The amount of evidence-based research that is now available regarding dizziness, vertigo, and falls in persons with diabetes is becoming exponential in its growth. And I would urge you to become more and more familiar with some of this information. We're going to move through this because we want to talk about some intervention. So I'm going to go through these next slides rather quickly, just to give you the impact of how much literature there actually is now. Brian, can you go to the next one? Okay. Again, these are some articles. One of them is a publication we just did the end of a year ago or so that looks at the prevalence of positional nystagmus and related to BPPV. We know that there's impaired balance, all ages, young and old. Brian? Here's some good information about exercise intervention for the improvement of fall-related outcomes among older adults with diabetes. And again, the systematic review and meta-analysis are very, very striking as what can be done as the way of exercise. Please go ahead. We also know that the comorbidity of diabetes is much more likely going to influence the prevalence of BPPV and recurrence rates. And we also know that when individuals are sedentary, when they become depressed, there's also an effect on cognition and mental health and depression. Next. all of the data that we're seeing strongly indicates that if you were going to identify one at-risk population for falls, the diabetic population is probably number one. Brian? I'd like to point out the article on the left is by Agarwal's group. Now, this was published a number of years ago. This is not a new article. This article is really important as it relates to the diabetic population, vestibular dysfunction. If you were going to take one article and try to share this with referring physicians in your area about paying attention, it would definitely be the article from Dr. Agarwal's group at Hopkins. Next, Brian. And again, we've got this. I want you to also look at the otolith dysfunction in persons with diabetes and benign paroxysmal positional vertigo. Again, one of the authors was my mentor at The Ohio State, Dr. John Ferraro. Very, very important topics. Remember, even though BPPV occurs in the ear, the vast majority of individuals with BPPV do not have a precedent ear problem. Okay, it manifests in the ear because that's where your gyroscope is. But the individual didn't necessarily have a labyrinthine concussion. They didn't necessarily have labyrinthitis, vestibular neuronitis. They're diabetic. Next, Brian. And these are some things we're doing. You can see that vascular changes in the saccule. That's an interesting topic. But you'll see also we've just been approved for our own IRB. We're doing a large multi-institutional research project with Jack Wazen and Herb Silverstein of the Silverstein Institute, looking at postural stability with individuals with BPPV, both with diabetes and migraine. Brian? So, as we start to look at the close of our hour, okay, audiologist, what can you do? Let's say you don't do any vestibular testing, okay? The first thing is to make sure that during the interview, there's a comprehensive medical history and review of symptoms and systems, because that's going to be very, very important. We understand that the person may be coming in because of tinnitus, because of hearing loss, because of some unsteadiness, because of some dizziness. But one of the most important things that you can ask them about is not just diabetes, but do they actually also fall within any of those categories of the pre-diabetic? Remember, 9 out of 10 pre-diabetics don't know who they are. So what can you do? Okay, what kind of screening or diagnostic protocols? Well, it depends where you are, where you work, what you have available, and we'll look at that. And then, how comfortable are you at making recommendations for additional evaluation and management directly to the patient, their significant other, or to the referring practitioners? Remember, in the United States, it's estimated that there's a shortage of approximately 90,000 physicians, which means that the referral source to your facility may not be a physician at all. It could be a nurse practitioner, it could be a physician assistant, but it may not actually be a physician. So you have an opportunity to create dialogues with those referral sources because they're going to be interested. They're going to have the time to listen to you. And of course, they can be educated. And that's one of the reasons that I provided you with all of those snapshots of the research information, because we find one of the best ways to influence practitioners' referral patterns is education, education, education. So, okay, I don't do VNGs. I don't have computerized dynamic posturography. I certainly don't have a rotary chair. What can I do? What should I do? Well, let's look at the next slide, Brian. Okay, So audiology, we've got a problem. And one of our problems is that, unfortunately, under Medicare and Medicare, most Medicare Advantage plans, we don't necessarily have access to evaluation and management codes, which means that we have a closed finite universe of CPT codes that we're able to use. So let's talk about some things. So, are there screening protocols that we could incorporate that maybe I don't get paid for, but take less than 5 minutes? Actually, some of these probably take less than 3 minutes. So what are some of the screening protocols that I might use? Number one, the interview for history of falls or elevated self-report fear of falling. Mary Tinetti, one of the gurus from Yale University on aging, geriatrics, and falls, has reported, and this is a very classic paper produced more than 20 years ago, said that the two most common indicators, or the two most sensitive indicators of who was at risk for a fall, were older adults who said, I'm afraid of falling, or have already fallen in the last few months. You could do a timed up and go test, also known as a tug, functional reach test, dynamic gait index, which is a much longer test. Timed up and go test basically is under 20 seconds. Functional reach test is certainly under a minute. The dynamic gait index is a more complicated test, and that really would typically, unless you're in a real balance center or you're working with a physical therapist, you're probably not going to do that. Clinical test of sensory integration of balance, the test developed by Horak and Shumway Cook, also known as the CATSIB, can be completed in less than a minute using calibrated foam surface. Because of the high prevalence of BPPV, you certainly can do modified Hall pike testing so long as you're using sideline or non-head hanging neck extension type of activities. For those individuals that are in a clinic that has advanced testing, then of course those well-known standardized tests, computerized dynamic posturography, whether you're using a Bertec or NATIS system, GAN sensory organization performance with CATSIB, VNG. There are several abnormalities you're going to see, as we talked about, whether it can be reduced optokinetics, positional nystagmus in the absence of BPPV, bilateral caloric weakness. The VEMP test, as you saw from the article from Iran, can show abnormalities. This is not surprising when you saw the other article on vascular changes in the saccule. Because remember, the cervical VEMP, the genesis of that reflex arc is in the saccule. And of course, rotary chair testing, which is my go-to test, because unlike the caloric test, the rotary chair is a true physiologic stimulation. You know, warm air, cool air, water, whatever you're going to use, is a very antiquated test. So rotary chair, video head impulse testing, these kind of things are going to be much more accurate than the caloric testing. Next, Brian. Okay, so what are some of the treatment and management options as we come to our conclusion, which should leave us then our time for calls or questions? Obviously, we know that BPPV is the gold standard for the treatment of cannula repositioning maneuvers are the gold standard for the treatment of BPPV. Whether it's the American Academy of Audiology, Physical Therapy, Otolaryngology, Neurology, Physical Therapy Association, everybody is on board and agrees that cannula repositioning is the treatment of choice for BPPV. It works. 97% of the time, you're going to get great results. Vestibular rehabilitation therapy may work if you have an acquired unilateral condition. Again, this is going to be administered hopefully by a certified physical therapist, occupational therapist, or audiologist. Balance retraining therapy is more devoted to those individuals that have a bilateral loss that don't have the ability to benefit from central compensation. Activities of daily living. This is making sure the person can get in and out of a shower that has an appropriate seating area or grab bars. The person is able to safely get on and off the commode. The individual is able to get in and out of bed safely. Addressing fall risks in the home environment. This can be a visiting nurse, could be an occupational therapist. Okay, is the lighting appropriate? Is their kitchen designed so that they're not getting up on step stools? And again, is the individual at the point where they really need to use an assistive device? I guarantee you, I don't know who's listening to this, whether it's audiologists, physical therapists, nurse practitioners, but how many times have you heard from an 86-year-old patient, they're not old enough yet to need help? And then you see them in the hospital. So we simply know that gravity always works, gravity always wins. So sometimes you just have to use some tough love with these individuals. Brian? So I want to thank you. I want to thank the Academy of Doctors of Audiology. I want very much to thank Dr. Kathy Dowd for bringing diabetic conditions and the diabetic individual to the forefront in the world of audiology. And I want to thank you for your attention. Please feel free to visit our website where you can watch. Everything is open access. It's free. You can have access to articles. You can watch video case studies. It's all free. If you want to reach out to me, feel free. My email is right there on the screen for you, rgans@dizzy.com. And I guess we're ready to answer any questions for you. Thank you.
Thank you, Dr. Gans. And at this time, if you have questions, please type them in the queue and I will read them out. First question, as a dispensing audiologist, what is the best route for referral for a fall risk patient?
Great question. I'm a big believer in primary care. Remember, physical therapists, patients rarely have direct access to them through Medicare, similar to the challenges of audiology. So it's a good idea to have a conversation with the patient's primary care physician about why you believe they're at risk, and also to give them some guidance. If you feel that you've been able to do some screening protocols, do you have a sense? Are there balance problems more related, do you think, to their eyes, their ears, diabetic neuropathy? Or it may just be that, look, Mrs. Jones, I'm going to give Dr. Patel a call and let her know that, I'm really worried about your balance. You've told me twice now that you've fallen and you're getting concerned about this. And I think it's time that we start to pay attention to it. And that may all be that you need to do.
Okay, next question. What is the primary physiological reason patients with diabetes have a higher incidence of BPPV? Is it typically vascular?
Yeah, vascular is absolutely it. If you look at the article that Richard Roberts and I published a number of years ago, which has kind of become somewhat of a classic on non-otologic comorbidities, what you'll find is there's a much higher prevalence of BPPV in diabetics, in migrainers, and in patients with cardiovascular disease and those with hypertension. These are all, and the common denominator is blood flow.
Great. Next question is, what is the specificity and sensitivity of M-Halpike testing in vestibular screening testing?
Oh, okay, great. Great question. Okay, so the M-Halpike, we say modified, the M stands for modified because we don't want to use the hall pike as it was shown in 1951, where you're hanging somebody's neck off a table like a chicken or a turkey at Thanksgiving, where you're going to decapitate them. We all know the dangers of vertebral artery dissection, particularly with an older population or that population with osteoarthritis. So the modified hall pike simply means that you're going to use a fully supported protocol. If you're not sure what those look like, go to the website and you can watch the video case studies. So let's talk about sensitivity, which means how good is it at finding the problem. The diagnosis for BPPV is done with a modified hall pike. It is 100% sensitive because you're going to provoke a rotary torsional nystagmus for the vertical canals, a horizontal linear for the horizontal canals. It will mirror the patient's subjective vertigo. It will fatigue along with the patient's vertigo. Specificity is actually, you're not going to have a high false alarm rate. That's what specificity is. So the modified hall pike is the go-to test for benign paroxysmal positional vertigo. You can pretty much take it to the bank. When in doubt, if you follow the work of David Haynes at Vanderbilt in his publication, if you treat individuals who have fatigable dizziness in the absence of nystagmus, 80% of the time you'll extinguish it with a cannula 3 positioning maneuver. And if that's the case, then you know that's what it was. Your treatment almost becomes your diagnostic tool.
All right. Next question. Are you familiar with the 4-stage balance test? I find it to be almost diagnostic of peripheral neuropathies. A recent research article noted a significant increase in sensitivity when ED nursing added the 4-stage balance test to their screening questions of if the patient had fallen within the last 3 months. Do you limit your activities because you are afraid of falling, etc.?
Yeah, and I think that it's excellent. And some of the, it's interesting. Years ago, some of, when we used to talk about clinometrics had a bad rap. Oh, that's not research. That's a paper and pencil test. But what we know over the last 20 years is that these things are right on the money. I mean, when you think about the DHI, the Dizziness Handicap Inventory, that Gary Jacobson and Craig Newman developed back in the 91, 92. I mean, this thing has been standardized and it's become the gold standard for dizziness. If you look at what Tonetti published back in the late 80s about questions, if you look at the American Academy of Neurology in these questions, individuals who tell you that they have fallen within the last 90 days or are afraid of falling, you can almost take that to the bank. It's no longer a question of if they're going to fall, it's a question of when.
Great. And that is all the time we have for today's session. If you have additional questions, please send them to info@audiologist.org and we will forward the questions to the presenter. As a reminder, course attendees will receive an email containing a link which will allow you to complete CE information and your assessment and evaluation. In addition, we will also send the PDF version of the slides. If you have friends and colleagues that were unable to attend the webinar today, please let them know that it has been recorded and will be posted to the members-only section of the ADA website next week. For more information about future ADA initiatives, please visit www.audiologist.org. Thank you and have a great day.